Upon Dr. Vishal to talk on diabetic macular edema clinical presentation, particularly role of steroids, lasers and surgery. Vishal is prolific surgeon, retina practitioner at Jaipur.
Thank you, Ajay sir, and thank you for making me a part of your wonderful course year after year. And I'll be speaking about the role of steroids. I'll be talking about the role of steroids and surgery in DME. Uh, Lasers will be covered by my subsequent speaker, Dr. Bhuvan. So, just a brief, we all know that the diabetic macular edema is a chronic and a multifactorial condition. It's one of the most common diagnoses we make in our retinal OPDs, and it causes a visual impairment that critically impacts a patient's quality of life. And traditionally and still, anti-VEGF agents are the gold standard for the first line treatment in the management of DME. But now we know that only around one third of DME patients show more than 3 lines of visual improvement with anti-VEGF, suggesting the role of basically inflammation in the pathogenesis of DME. And so many molecules are involved, and it has been proved, like addition molecules, ICAM, VCAM, integrins, IL-6, IL-8, and the role of Ang2 has been well established in the pathogenesis of DME. So, besides VEGF, there are various pro-inflammatory agents responsible for diabetic macular edema. And even if you see the data for anti-VEGFs among the eyes that showed limited initial visual acuity improvement with anti-VEGF monotherapy only one third of them showed a clinically significant long-term visual response, and at the end of the 2 years, the response was very less, and at the end of 3 years, it was less than at the end of 2 years. So the current perspectives on the role of inflammation in diabetic macular says that DME patients have elevated concentrations of these pro-inflammatory cytokines, IL-6, IL-8, MCP1, and of course VEGF. And for the concentration of the remaining cytokines, there was no difference between patients with DME and healthy subjects. So, what about dexamethasone? Is it effective in inhibiting inflammatory cytokines in DME? Well, the evidence says so. So, you can see the percentage of patients with a 3 line improvement from BCVA from baseline at the year 3 or final study visit. It shows a significant improvement in visual acuity. Even Dex implant 0.35 mg shows statistical superiority to sham patients. And eyes with anti-VEGF treatment in the first year, and they were switched later in the second year to steroids, also showed functional and anatomical improvements. And of course, those who switched early to dexamethasone in the first year, of had better visual gain. So eyes that switched early to dex implant had, of course, a better outcome because at 12 months, and could maintain it across the second year. And those who switched did not have that much improvement, but still they were better off than the previous anti-VEGF treatment, of course, because of irreversible photoreceptor loss. So why are we in our clinical practice hesitant to give steroids early in diabetic macular edema? Of course, the most common answer would be that we are, still averse with the, adverse effects like cataractogenesis, maybe IOP rise, and we all know that that can be easily managed by medical management, and cataractogenesis is not a very major problem, and the main concern is that we ourselves do not know that how many, what subset of patients have suboptimal treatment outcomes with anti-VEGF. We keep on injecting anti-VEGF, and many of these patients we do not follow up regularly to see the magnitude of suboptimal treatment load. So the guidelines say that it is the DEX implant is a preferred, you know, steroid therapy among all the available corticosteroids. It can be used as a first line in pseudophakic eyes. It can be used as a first line in patients with cardiovascular events, and those patients who are unwilling to attend monthly or regular anti-VEGF treatments. So the indications are steroid use is history of major CV events. Pseudophakic eyes is a first-line treatment, and in phakic eyes, of course, anti-VEGF is the first-line treatment, but can be given to patients not willing for regular checkups. And the expert recommendations using Delphi-based approach recommends that apart from the previous recommendations, you can consider, DEX implants in patients who are not responders or suboptimal responders after the loading phase of anti-VEGF. And among steroid treatment, dexamethasone intravitreal implants were considered to have the best ocular tolerability. So just to summarize, the naive eyes, treatment naive eyes, suitable patients are pseudophakic patients and not suitable for anti-VEGF agents or poor treatment adherence. So it gives good anatomical response, faster resolution, and does not cause systemic adverse effects. And in switch eye, non-responders, that after the loading dose of anti-VEGF, if there is only a less than 10% reduction of central subfield thickness or less than 5 liters of BCVA. And in inflammatory scenarios, on the OCT, if the diabetic macular edema shows the telltale signs of inflammation, that is the NSD, neuroepithelium detachment, or hyperreflective foci. So the key takeaways about the role of steroids in the management of DME is that, of course, we know that still the first line of treatment for DME is anti-VEGF agents, but many patients fail to show a visual response after a prolonged anti-VEGF treatment protocol. Inflammation is the main culprit in these non-responders, and intravitreal corticosteroids are useful in the management of DME as they block the production of VEGF and pro-inflammatory cytokines. So they show efficacy in the treatment of DME along with the favorable safety profile. So coming to the surgical aspect of the treatment of diabetic macular edema. So let's divide it into 3 parts. First is, of course, it's a recognized definite indication, that is a taut posterior hyaloid membrane, vitreomacular traction, and epiretinal membrane, which is causing actually a physical macular edema. A relative indication is a non-responder patient, that is a patient with recalcitrant macular edema after a prolonged therapy of anti-VEGF, maybe steroids, and still has persistent macular edema. And now studies have come up with treating ILM with vitrectomy and ILM peeling in treatment naive diabetic macular edema. I do not do that, and I think that comes in the category of overzealous treatment, but it remains to be seen what are the results. But all these indications yield excellent anatomical results with reduction in central subfield thickness. And the rationale is that vitrectomy, by doing a vitrectomy, there is improvement of vitreous oxygenation. There is a reduction of the cytokine levels and vitreous VEGF levels. And ILM peeling per se is beneficial for the resolution of DME and visual acuity improvement. So just a couple of videos to tell you how it is done. It's a straightforward surgery. This is a patient of taut posterior hyaloid membrane, and a PVD induction is there. You have to stain multiple times to reach the ILM because every layer has to be peeled separately. You can see this glial white tissue, and that is your taut posterior hyaloid membrane, and it comes easily with the forceps. You don't need you don't need even to stain it, and it's actually very it comes in one piece. And after that is removed, you again stain it with the brilliant blue dye so that the ILM now takes up a good stain. And this is the final peeling. So we have removed the vitreous, did a PVD induction, removed the taut posterior hyaloid membrane, and the final step is to peel the ILM. Of course, the traction was resolved and the patient had some improvement, but you can see that a subfoveal plaque over there, which did not, nothing could have been done for that. So this is the pre and the post OCTs. Another case of taut posterior hyaloid membrane. Here, the visualization was poor, so we injected trypan blue to stain the taut posterior hyaloid membrane. So it was, just forward it. So you catch hold of that with the end gripping forceps. Just the last video. And again, it, comes up as a sheet. In this case, it was bluish in hue because of the trypan blue staining. And the final step is the common ILM peeling after the third staining by BBG. And this is a peeling in a non-tractional edema for a recalcitrant macular edema without any TPHM or without any VMT. And you just do a simple ILM peeling in these cases, and the results are very good. Although many of these cases do not, the visual acuity improvement does not resonate with the anatomical reduction in central subfield thickness. So to conclude, vitrectomy for DME, the indications and extent keeps on evolving with time. No diabetic vitrectomy, mind you, especially for the youngsters, is a straightforward procedure, and you might end up in complications with poorer visual acuity than pre-op visual acuity. But of course, it remains an important tool in the management of select cases of DME. And the concept that thinner macula doesn't correlate with improved visual acuity should be made adequately clear during the pre-op counseling to the patient. Thank you so much, and I invite you to the National Indian Retinopathy of Prematurity Society conference to be held in Jaipur in July this year. Thank you so much.
Thanks, Vishal. That was wonderful. Bhuvan, can you come for your presentation next? Bhuvan will be talking on current role of lasers in diabetic retinopathy in the anti-VEGF era and the newer lasers. We welcome Dr. Mangat Dokra. We thank you for coming for the course, sir. Welcome.
So very good morning to all of you, and I'd like to thank Dr. Ajay for including me in this course, and we have been conducting this for the past 3-4 years now. So I think all the interesting part of anti-VEGF and surgery has been done. So I'll be focusing on the boring part, that is lasers in in diabetic retinopathy, but still it is very important, the medical management of diabetic retinopathy, and few new laser techniques which have come up, although I have not used most of them, but I'll just discuss their role. So I think laser still plays an important role in the treatment of diabetic retinopathy. This is the question, and I'll just try to answer it despite the popularity of the anti-VEGF agents. So before anti-VEGF, I think laser photocoagulation was the first line both for PDR as well for DME, but with anti-VEGF agents, we have got improved superiority, increased vision gain, and hence the role of laser is coming down and down, especially in DME. So this was the classical definition of high-risk PDR. Just for information, I'll not go into the details. So in the ETDRS, in the DRS study, they showed that PRP treatment will reduce the chances of severe visual loss by 50% or greater. So this is a classical PDR with NVD or NV, which can lead to further complications of vitreous hemorrhage, TRD combined NVI and leading to NVG. So the main treatment for PRP is a pan-retinal photocoagulation, which should be done with a wide field lens. You should completely cover the retina 360 degrees as anterior as possible, because most of the diabetic patients will have their ischemia anteriorly, although a posterior variant has also now been discussed a lot, but still I think a good pan-retinal photocoagulation up to the aura should be done in a case of PDR, especially in our country where the follow-up is not very good. Even if there is an early PDR, it's better to do a pan-retinal photocoagulation. So this is the standard procedure. I'll not go into details. I think everybody who is practicing retina knows how to do a PRP laser. So what were the disadvantages? There are several disadvantages which were there with a PRP laser, a conventional one. It causes a lot of discomfort. We have to do it in multiple settings. It can lead to scarring, and sometimes it can even lead to collateral damage to the other retina, decreased color vision, night vision, and even a contraction of the visual fields. And sometimes it can lead to choroidal effusions or raised IOP with risk of choroidal detachment. So these are the newer things which have come up. One is a targeted retinal photocoagulation. You should have ultra wide field angiography for that. What is targeted retinal photocoagulation? That you can just do a good ultra wide field angiography, locate the areas of ischemia and ablate only those areas of ischemia which are the source of the VEGF. So we eliminate that. So few studies have been done. I think it can be done only in the early stages, but again the patient has to have a very good follow-up if you're doing a targeted retinal photocoagulation. I've done in few patients, but the most important thing is a good follow-up, because if there is further ischemia, it can lead to further damage of the eye. The other laser are the pattern scan laser or the Pascal. What they have got a different set of patterns, and they really reduce the time. The patient comfort is also improved with it. So they are in the form of a square or an arc or a grid, and it really reduces the number of settings and the patient comfort. But there is also a disadvantage which is there, that it is less effective as compared to a standard pan-retinal photocoagulation. So there are studies, and I have even seen that sometimes the NV is not regressing very effectively, and it is better to do a complete PRP conventionally. So as I said, it reduces the time, it increases the patient comfort, and as it has got shorter pulsar durations, it leads to less tissue damage of the inner retina. So the drawback I've just highlighted, that there are cases which can have a recurrence of the NV or non-resolution of NV, and it is less effective as compared to conventional PRP laser. The other is a Navilas. I've not used it, but that is an image-guided laser system. So it specifically targeted retinal photocoagulation and predetermined in a highly precise manner is done. It uses infrared images, color photographs simultaneously, and you can go ahead with the laser. Again, it is very comfortable for the patient, lesser settings, but it is less effective as compared to a conventional panretinal photocoagulation. It can be even used in the management of DME. I'm just speaking about PDR at present, and it is a very highly efficient manner. It has been showed in studies up to 12 months the macula remains dry. So now anti-VEGF role in PDR. I'll first discuss PDR. So according to the DRCR.net protocol S, so they were giving anti-VEGF injections every month. They gave it for 2 years, and they said that there is no need to laser, but this is not a viable option because most of the anti-VEGFs, their effect is up to 6 weeks or maybe 8 weeks maximum, and there is a very high chance of recurrence of these neovascular vessels, which can lead to severe complications like NVG. And somehow I think all of us are noticing that the incidence of NVG is increasing, not only because of PDR, probably even in CRVO cases, we give anti-VEGF agents and we don't call the patient, and the 100-day glaucoma has classically become like 1000-day glaucoma. So the patient, because we are not eliminating the ischemia by giving anti-VEGF agents. So in our country, it is not viable financially and for medically also. So for me, for PDR, PRP is still the gold standard. Coming to the second aspect is diabetic macular edema. It is the most common cause of legal blindness in India. This is again the classical definition which we had when I was a postgraduate. I think you should know it, but now we are mainly focusing on center involving DME and non-center involving DME based on the OCT pictures. So in the ETDRS, when they did a grid laser or a focal laser, they said that reduces the risk of moderate visual loss. However, visual gains were very limited. So it's very good to have these new anti-VEGF agents also. So because of this laser, there was a high chances of scar, even developments of choroidal neovascular membranes, and collateral damage was there because the laser scar tissue tends to increase over time. So as I said, these newer agents, they have really increased the visual results. I not go into the details, they all have been discussed. So the main treatment for DME is now, which I follow, is protocol T. I think both aflibercept, ranibizumab are very effective. We even have got faricimab, that is also very effective. But if the patient can't afford, you can go with the basic ranibizumab, and over a period of 2 years, that has shown almost equivalent results to aflibercept. But the catch is here that more than 50% of these patients after 2 years will have a recurrence and will need some adjuvant therapy like laser or a steroid. So laser still has a very important role even in the DME. So these are the, as I said, one is focal laser and the diffuse laser. These are the newer modalities which give a sub-threshold laser and they prevent the damage of the collateral damage. And Navilas, as I said in PRP, it can also be used in DME. So selective retinal therapy is also, it gives very short pulses duration. I have not used it. So I'm just saying because newer techniques, and it prevents the treatment of the selective treatment of the RP, preventing the inner retina. Hence, it is much more safer as compared to doing a conventional laser. Same is the sub-threshold diode micropulse. I think Dr. Ajay really has used it a lot, but I have not used it. So the main role is that it prevents the damage of the retina. Even lesser collateral damage is also there. So it uses a near infrared diode lasers, and there is a burst of these laser which comes in sub-millisecond pulses, and it's quite safe to the fovea. So similar to SRT, SDM also provides selective therapeutic targeting of the RP, and there is no visible intraretinal damage or scarring either during or after treatment. So this is to summarize all the lasers which I just discussed, in which you can, in which pattern laser and Navilas can be used both for PDR and DME. However, selective retinal laser and micropulse can be used only for DME. The main important role is that they prevent the damage, the collateral damage to the tissue. Now coming to what is the role of the DME in the anti-VEGF agent, laser has become the second line treatment for center involving DME, but it still holds a very important place. And once you do a laser, especially you do angiography, you can see those extra foveal leakage points, and you could do a focal laser that only reduces the edema but also reduces the number of injections which are required. So it's very important to have a very good diabetic control also. Once you're doing a laser, it takes up to 2 to 3 months to the effect to come. So don't be in a hurry if you've done a laser that you want to see immediate effect. So when should we do a laser in a DME? Once, for what laser can be considered as a first line when there is a non-center involving DME, or if a patient has got a recent stroke within 2 months, or a heart or a MI, and the patient is also contraindicated for the use of steroids, probably because of glaucoma or some deep cups. So that is a case in which you can do a FA and we can do laser as a first line therapy. And of the good thing of laser is you don't have to call the patient again and again. So, and laser therapy, as I said, can always be considered as a second line or a adjuvant therapy to anti-VEGF or steroid agents in all cases. So, as a rescue laser, as in the protocol T, as I said, rescue laser was done in approximately 40 to 50% of the patients after a period of 2 to 5 years. Most of them required lasers. So, this is the most important thing for while you're managing a proliferative diabetic retinopathy or a DME, that is the intensive control of blood sugar. These are the studies which have been done. I'll not go into the details. So a good control of diabetes, a good control of the systemic condition and the hypertension is very important for management of both DME as well as proliferative diabetic retinopathy. So my take home message is for PDR, laser PRP is still the gold standard. We can't replace it with anything else. Newer laser patterns, they give more patient comfort, they are much more safer, lesser time, but however in some cases they are not as effective as a conventional PRP and they can lead to a resurgence of the neovascularization. Anti-VEGF agents have really become the first line of treatment for DME, but laser still has a definitive adjuvant role as a focal laser in most of the cases. And the other novel techniques of SRT and SDM, they are a new laser modality that prevents collateral tissue damage for the treatment of the macula. So thank you all.
Thank you, Bhuvan. You did a wonderful job with the lasers. Thanks. We'll have the questions at the end of the session.
Sure, sir.